I think that particular treatment will work. What are the data? What do the data tell me? As this particular condition, certainly this child may not have been treated before, but if children like this one with problems like this child is presenting with, have there been trials of different treatments for this condition? And what do they tell us? And Dr. Kurel reviewed the data that we do have available. It needs to be evidence-based and it needs to be individually tailored. Maybe I go up more slowly on medication in this child, more rapidly. Maybe I make adjustments. So essentially, the treatment needs to be evidence-based and individualized. And it needs to be with defined targets of treatment, and then you go on to measurement-based treatment. The first issue we talked about was individualized treatment. The second issue is monitored. You need to measure. You need to measure benefit. You need to measure risk. Is the treatment working? How do you know it's working? Well, I think the child's better. In what way? Is that the this that you were targeting better? Because it was the this that was contributing to problems in the child that you wanted changes in. Is the treatment working? It's best to use reliable methods of assessment. Rating scales, they don't have to be complicated 1 hour, 45-minute rating scales. They can be simple rating measures. You've defined a particular target. You use a clinical global improvement scale for that particular target, but make sure that you're measuring, you have some reliability, and you have some anchors, if you will, with regard to how you measure. But assess efficacy. Assess if the treatment is working using some instrument that's reliable. Very importantly, if you find the treatment not to have worked, see if you've used the treatment appropriately, optimally. But if you have stopped that treatment, one of the problems we get into is when we talk about polypharmacy or using multiple different medications. One of the reasons for that is we add, we don't substitute. We don't stop treatments that don't work. We're more reluctant. It's not, I'm sorry for that's an exaggeration. We do stop treatments when they don't work, but we're more reluctant. We're more loath to stop treatments when we find them not working. So the key is, if the treatment is not working, let's stop it. Side effects. As Dr. Kurel pointed out, we need to use a specific protocol to be looking at side effects. Is weight changing? That should probably happen at every clinic visit. Measure the weight. Waist circumference, perhaps, if you feel it's, it should be measured periodically. Lipid levels, cholesterol, triglycerides. There are some measures that are more sensitive than others, some that change at different rates than others. We need to be aware of that information and assess appropriately. But we need to measure, and we need a protocol for each clinic and for our practice with regard to classes of medications that we utilize as a template, and then we individualize based on the particular child, if you will, and the treatment that we're utilizing. So use a specific protocol and then individualize based on what treatment and what the vulnerabilities of child might be. And then, again, initial treatment, ongoing treatment should be individualized based on risk-benefit considerations, which change over time. So do the risk-benefit analysis at each step of treatment. And lastly, it should be informed. Certainly the treater needs to be informed. The evidence that Dr. Kurel presented. I mean, one of the things that's going to happen when you leave the room is all of you are going to receive a 200-question multiple choice protocol. And before you are able to prescribe again, Christoph, you've got that done, right? You didn't bring oh my God, okay, it's not, then maybe next time, next time. But the point being, the clinician should be informed about the best evidence at this time in terms of risks and benefits. The treated child, guardian, needs to be informed. And the fundamental questions, when I go and take my child for any problem to a pediatrician or to any specialist, these are the questions I ask. So I trust the doctor, I trust the person to kind of do the best he or she can for my child, and the expert knows much more than I ever will, but I still want some basic questions answered. What is, if you're prescribing a treatment, what is it exactly for? What is it for? What do you expect? Exactly what are you targeting? What do you expect to see? How will you know it's working? If it's working, how long will you continue it? Lifelong? For a short period of time? Exactly what can I expect? And how will you know it's not working, if you will? So basically, fundamental questions that we should be able to answer. What's the condition? What are you targeting specifically? It's not just a diagnosis, because there's a diagnosis and then there's a specific target of treatment in this child that I expect to get better. That we talked about. What are the alternatives available? What's the likelihood of benefit? What are the known risks? Before I sign on to any treatment for any condition for my child, I want these answers. Why should we choose this particular treatment? Why this medicine? Or why medicine or this class of medication? Why not that? I've got bipolar disorder. Dr. Carell, you're prescribing aripiprazole to me, but even before I get to aripiprazole, why antipsychotic? Why not lithium? Why not an anticonvulsant for my child? What prompted you to make this choice? And so, other questions. Okay, so you've decided to use this treatment. How will we know that this medicine is working, this treatment's working? When will you evaluate? Oh, in a week? In 6 weeks? In a day? How will you evaluate? Are you going to use rating scales, doctor? Are you going to use some kind of checklist? Or are you going to use a frequency of a particular... How are we going to know that this particular treatment is working? How are we going to measure? And if it works, how long are you going to continue it? If it fails, what will we do next? What are my options? So these are the elements of informed consent. Understanding the use of the medication. Why, for what to expect, pros, cons, alternatives, etc. Another piece of it, another issue, well, okay, you've decided to prescribe this medication. Are there special precautions? If this is, for example, a number of our treatments are alpha-adrenergic blockers. They cause hypotension. Do I need to take special precautions with regards to that? So what are the special precautions? And the third element is, well, then finally I authorize a treatment, if you will. Now, why do I lay these things out in this manner? Because there is a particular population of children where these issues become difficult to translate into practice. That's children in our child welfare system. Because children in our child welfare system, their parenting role is fragmented. Now, if I am taking my child in to see the doc, I need to know, I'm going to provide authorization. I need to know what the treatment's for. I need to know what the precautions are because the child lives with me and I will monitor the child and I'll make decisions for the child with all this information. But in the child welfare system, these roles are fragmented. So if you've got a foster parent that the child is living with, that foster parent does not have the authority to authorize the use of medication. Yet the foster parent clearly needs to know special precautions that need to be taken and what to watch for. If the child is getting better, what to expect with the treatment. You've got the case manager, you've got the courts, you've got multiple different players in this particular system that are playing different parental roles. So how do the different parties know exactly what role they need to play? And how are they allowed to play the different roles they need to play? And how is all this coordinated? A challenge, particularly in the child welfare system. But let's go back to where we started. And the good news here is the state perspective has been exactly the perspective that we thought was the proper perspective. This is the state perspective. What the state wants is appropriate use, which means individualized care, monitored treatment, informed treatment. Psychotherapeutic medications in conjunction with other appropriate treatments and